So the key question for a predominantly adult-based population where you treat some children is, can you do the same technique in adults that you can in children? And I'll quote you two papers. The first comes from Peter Fauner in Denmark in Aarhus, who looked at a series of kids with a mean age of 11 and a half, transphyseal ACL reconstruction with MRI scan post-operatively. He found that a quarter of them had a centimetre of shortening and over 80% had valgus of the distal femur, and that's the pattern on the picture that you get with this failure. So it tells you that if you look closely, failure is properly there. If you look at more recent contemporary literature, this comes from the group in Toulouse, Frank Bled, who looked at 50 kids, all at a young age group. What he found was that growth disturbance was independent of age. It didn't mean that if you were younger, you were more likely to get it. But half of them had a difference in their tibial deformity and a third in their distal femur. And Frank does what I would call a physeal respecting transphyseal reconstruction. It's very different to what we're doing in adults. So the key thing to remember is that the more horizontal your tunnel is, the more physis you're going to take away, and also the closer your fixation on the femur is going to be to the perichondral ring. And we know those are things that can lead to failure. So if you are going to perform transphyseal reconstruction in kids, do the things that the BOSE guideline tells you. Perform a pre-op long leg film to assess for deformity. Calculate their bone age. It's important to know how much growth they've got less. Respect the physis. This MRI is someone who accidentally had a scan done 6 weeks at post-op to look at a meniscal tear. Look at the bone edema around the physis in both the femur and the tibia. And remember, follow them up until they finish growth, and it doesn't matter how old they are, they can still get growth disturbance if their physes are open. But there are other options that we can do that will preserve the physis, such as this, the All-Epiphyseal ACL Reconstruction, where you drill your sockets just in the epiphysis of the femur. It's a technically difficult technique. You require X-ray. You've got to fit everything into theatre. You need jigs. You need to be able to do an all-inside ACL reconstruction. And there are pitfalls in children. We often make the graft too long because we're terribly worried about it being too short. Physeal damage still occurs, and also when you're reaming out, because the bone is quite small for these tunnels, you can actually leave yourself with no bone bridge to tighten and fix your ligament. And we know from the work from Hospital of Special Surgery with this technique, physeal damage still occurs. And if you get it wrong, you take out the reserve zone of the physis, it's going to cause more of a problem in the first place. The other option that we can consider is avoiding the physis completely by doing an extraphyseal reconstruction, such as the modified Micheli, which is a great technique, and it works really well when the kids are really small. Although it's not truly an anatomic graft, it sits pretty close to where it should be, and in our practice at the Children's, we use it for the congenital absent ACLs and also where the bones are really, really small. And here's an example of a 10-year-old who's had a motocross injury. If you look to the far right, his bone age suggests he's very similar. So he's probably got about 6 years of growth remaining. And that's what it looks like. You can see it's a combined technique that includes an extra articular element as well, and leaves you with a pretty good graft. And the outcomes in the literature for this young age group are really good. Lowest re-rupture rate when you look at midterm follow-up. I think with Peds ACL, you know nothing except that an operation is bad if you follow up to 2 years. Also, growth disturbance is not going to be an issue with this. There were concerns about thigh asymmetry, but that's not something we've seen in our SCH series, which is at about 60 patients at the moment. So this is the algorithm that we use. Now, algorithms are not evidence-based, but what I can tell you is that over the years, since 2015 when I started, we're seeing a squeeze on the physeal sparing conditions with tunnels. So we're doing more transphyseals and we're getting younger in how we're doing them, but we're doing them carefully. But the extra articular procedures, we're now doing them more as we've seen that functionally they're better and their return to sports and their functional outcomes are really good.